You can start.
Good afternoon, everyone. Today I'm here to talk about a model
Timer.
which was designed by us for early vitreoretinal training. So VR surgeries, as we all know, are complex and require focus of the retina with the visualization system along with manipulation of the instruments in an enclosed chamber. So training of novice surgeons for these multi-layered surgeries is a big challenge. Initially, the traditional approach was observing the competent surgeons and then practicing onto the patients. Use of animal eyes is another approach, but it is limited by their availability, need for separate instrumentation, and poor visibility. Simulators, though, are an excellent tool, but are expensive and not readily available. Recognizing the limitations of all these approaches, we designed a simple, cost-effective retinal surgery model, the RetiSurg, created via 3D printing.
Model eye
Technique.
is designed using 3D printing. An eyeball is sketched based on its anatomy, which is then incorporated into the CAD software with appropriate dimensions. The model consists of two hemispheres. The upper one is made up of flexible material, that is TPU, which has same tenacity as that of human sclera. The lower part is made up of PLA. Preparation of the retinal film. A colored printout sheet is folded into a hemisphere. Using the concept of cave comb wrapping, a 3D printed tracer is used to customize the fundus printout so that it fits perfectly into the eyeball model. For a realistic fundus image, we can print it on a PETG sheet and then shape with thermoforming technology. The microscope handle cover is fitted into a cardboard box with a hole in the center. The model eye is then placed over this assembly. Two ports which simulate the superior sclerotomies are made in the eyeball using the 23-gauge tricars. These ports allow the introduction of the instruments into the posterior segment. This assembly is then used in conjunction with the operating microscope fitted with the biome to visualize the posterior segment and practice various steps of VR surgery. The most
Coming on to
important
the applied
aspects
aspect.
of VR surgery is the focusing and adjustment of the microscope to obtain an optimum view of the retina, especially the periphery. Beginners face a lot of trouble in this aspect, but it can be overcome with practice using this model. Manual dexterity is the basic skill required for all VR surgeries. This model helps the trainees to achieve the desired flexibility of the non-dominant hand required for performing bimanual maneuvers during these surgeries. RetiSurg can also be used to practice the basic component of core vitrectomy, that is, illuminating the retina and the vitreous to be removed without losing the focus of the microscope. Endolaser can also be practiced on this PETG film. The burns resemble those on the human retina, and the power settings are comparable with the real-life scenario. Further, it helps beginners in developing the sense of awareness regarding the position of instruments inside the eye to avoid inadvertent complications like retinal touch.
Now, the advantages. It's an economical model which was prepared by using indigenous materials in our hospital. It's a reusable model. By changing the retinal film, it can be used multiple times. Can be sterilized using ethylene oxide, and since there is no biological tissue used, it can be used inside the regular operating room. Limitations include we cannot practice all the surgical maneuvers with this, and secondly, it simulates the fundus view of an aphakic eye. Thus, RetiSurg is a simple, cost-effective, and reusable model for early vitreoretinal surgical training. It has already been published in AIOS in 2021. Thank you. Thank you.
Dr.
Excellent
Daswala, sir.
presentation.
Thank you.
Excellent presentation. What is the cost that is coming up? You said economical. How economical is this?
Sir, actually, if we count the cost of a 3D model, which is if the 3D printer is available in the hospital, then it's costing less than $300.
That's very good.
If the printer is available.
And reusable, how long, how many punctures and this you can do?
We can do
How
as
is it
many as...
reusable? Because once you puncture it in,
Yes.
how do you reuse it?
So we can make puncture at a
It gets auto-sealed once
Yes,
you take
sir.
this
Yes,
thing
sir.
out?
Yes, sir.
Okay.
Like we can make as many punctures as we want, and just the film we have to exchange because we are doing endolaser. The film gets there's no space for endolaser further, so we need to change the film. Rest all steps can be practiced with the same model.
And the laser burns are as actuals, the way we
Same,
have
so
it.
power settings, everything
Because
is
of the
same.
film that you're using
Yes, sir.
inside. Okay. Thanks a lot.
Thank you, sir.
Yeah, very good innovation.
Thank you, sir.
You could have gone a step further and maybe incorporated some membranes. Maybe
So we are-
incorporated blood
we-
clots, simulations of blood clots.
We are doing it with using the glue, sir.
Ah.
But we are not very successful in doing that because the instruments, no, they are not like we are not able to reach the posterior pole because of
the basic steps of vitrectomy are not very difficult to learn. What is difficult is the membrane surgery.
So we
use
are
of scissors and forceps is also
yes, sir.
equally
We are
important.
attempting that, but the posterior to reach the posterior pole in this is a challenge. So what we are
What is the diameter?
so it's like the entire thing is around 5.5 mm.
Why should it be that much? 5.5 mm.
No, sir, centimeters. Sorry. If we measure it from the
Why can't you make it the size of an eye?
so that only we are trying like in the next 4.5 centimeters, but in the next models we are making it around 3.5 for the instruments to go for ERM or like the membrane removal practice.
Okay. So there's no cornea. It's just
No, sir.
just an
There's no
opening.
cornea.
Regarding the vitreous gel, you're planning something artificial
So
to have it
we,
because vitrectomy
we
mainly.
attempted actually we are putting viscoelastic so
Yeah.
that we can take it inside the theater.
Huh.
But outside the theater, some of the people have, like in our institute only they have tried using egg white. Egg white is not the egg white, the yellow portion. In that it's exactly similar like vitreous. We can practice cutting also. But the drawback with egg is we cannot take it inside the theater, and all the machines cannot be taken out to the wet lab.
Quite right. Only thing is the 20 inch. If you have a 24 millimeter size eyeball,
Yes,
that
sir.
will be actual. We are doing it because here
Yes,
you'll
sir.
have a lot of space.
Yes, sir.
People will see it's very comfortable. But
Yes.
once you go hands on and do it on the real eye, it
Yes,
might
sir.
turn out to be difficult. But what he suggested, Dr. Guru Prasad, I think will be a very good idea to have eyeball size.
So we are doing it like in the next models. We have already attempted doing with the glue and the membrane peeling forceps. But the size is an issue. The next model which we are getting, it will be of around 2.5 to 3 centimeters.
Fantastic innovation. Thank you.
Thank you so much, sir. Thank you.
If no questions, then we can move on to our. Thank you very much, Dr. Kanika. So can we call?
Yeah, Dr. Neeraj.
Yeah.
And who's going to be the discussant? That is a discussant. for him.
So his topic is slit lamp assisted toric marker.
No. After Neeraj, let Prasanna present. Okay, because he has to go for that LDP as a debate.
So I request Dr. Rohit Shetty and Dr. Gopal sir and Dr. Sri Ganesh to please moderate this.
After
this thing.
Prasanna.
Of course, Dr. Satyan sir, if you have any doubts, you can definitely pitch in.
I had allocated a judge for the second speaker in a. No, finance ke liye bhi I have allocated.
It's okay. Let him start. Okay. All the best.
Okay, good afternoon. I'm Dr. Neeraj Asrani. I'll start my video and then we'll have the discussion. Start the video, please. Yeah.
Come soon.
The authors have no financial interest in this presentation. Presenting to you a novel patent pending slit lamp based toric marker. There have been various innovations in axis marking, right from the anterior stromal puncture, the pendulum marker, and the bubble marker. On the other hand, automated markers such as the Varion, the application-based marking, and the Callisto image-guided system are also there, but however, they are very expensive. Manual handheld toric markers invariably give us a picture like this, which is completely off the axis. So we had a research question. Can we actually innovate an economical, accurate, stable, and easy to use toric marker? We took inspiration from the Goldman's applanation tonometer, which goes and indents the cornea of the patient, and the patient is not hesitant at all. We decided to use the calibration slot, which is universal in every slit lamp, for our slit lamp based toric marker. This was the first hand-drawn diagram of our toric marker. We further started doing 3D printed models. As you can see, the 3D printed models became bulkier every time. Thus, we finally settle with a shaft within a shaft, that is the IV stand design. Now, coming to the first prototype of our device. As you can see, we have implanted it into the calibration slot of the slit lamp. With the help of the knob of the slit lamp, we move it ahead. It goes and indents the cornea at the desirable axis. Again, with the knob, we take the slit lamp behind and it comes back to its original position. Now, the final prototype consists of a dial with a shaft made out of stainless steel. The dial is rotatable 360 degrees and has an achromatic edge. On the other hand, the adapter or the body of the toric marker is along with a plate to accommodate a levelometer called as the bullseye levelometer. This bullseye levelometer makes sure that the toric marker is perpendicular to the table of the slit lamp. Storm is now published in Indian Patent Journal and is in the final stage of hearing as long as the patent is concerned. Thanks to Epsilon USA, we have now come up with the final product. As you can see, the final product is made out of extremely lightweight aluminum and the marker is made out of titanium with very precise and sharp edges. The same procedure is done again where the marker is placed into the calibration slot. The bubble marker makes sure that the storm is perpendicular to the slit lamp table. The toric marker is then fixed using the screw, as you can see, and with the help of the knob of the slit lamp, the marker can be taken ahead or behind. And as you can see, we mark the toric marker using the blue ball pen, and the eye is indented beautifully and the patient is very comfortable as seen over here. This is how the marks appear on the eye. It not only leaves a mark but also slightly indents the cornea at that particular axis.
Thank you.
Thank you. Can we? Yeah.
Yeah.
Could you help for the mic, please?
Could you help for the mic?
Yeah.
Yeah. So nice innovation.
Thank you, sir.
Did you do any validation tests?
So we've compared it. I had a free paper also on this. We've compared it with Varion. So what we've done is we've actually marked the preoperative axis using this. And on the Varion, what we've done is we've taken image and applied a digital planimetry software, which basically gives us a deviation in an axis from this mark to the Varion's mark. We have seen a minimum deviation of, in 50 eyes we've done this, and minimum deviation of 2.07 degrees, maximum around 4.5 degrees with this as compared to the Varion. So yes, we have, that is also going, this is published in IGO videos. It's going to be published in IGO paper also, sir, very soon.
2 degrees again is significant. And do you find any, because many times when you mark with ink, then there is it leaches and then the marks are quite thick.
Yes, sir.
So that itself can give you like 2 or 3 degrees. So you have 2 degrees, another 2 degrees will be like 4 degrees.
Actually, if you see, it's like a small slit, so it does not leave a very thick mark. Not only that, it's actually pretty sharp, so it also slightly leaves that indentation also. So even if you put paracaine, it usually, even if the marks go away, that slight indentation is like an anterior stromal puncture is still there in that, sir.
So have you compared it with other handheld devices like gravity markers and bubble markers?
Yes, sir. We have compared it to anterior stromal puncture and the bubble marker. Unfortunately, it is difficult to compare it with that because bubble marker only does a 0-180. This has a rotatable dial, so whatever is your desirable axis, you can mark that also. So I have compared with like a freehand slit lamp marking also. Obviously, there are the p-value was significant as compared to this, but there was again a deviation. This seemed much better than the freehand marking, because like you said, the marking in freehand is much thicker. That itself gives a little more
But
deviation.
freehand also, you get epithelial markers. You
Free-
get the triple marker, epithelial marker, which gives an epithelial indentation, and you have a very fine line.
no, I'm not
You
compared
are
with
not
those
compared
markers,
with
so
those.
no.
They are gravity markers.
Yes,
So
sir.
you always get it at.
Yes, no, I'm not compared with
you're
those.
not
I'll
compared
do it. It's a good suggestion. I'll
And
definitely
how
try.
many eyes? What about deep set eyes and small eyes? Did you have any difficulty in marking deep? Because that
Sir,
is usually.
Yeah. Initially, the dial was much bigger. If you see the latest one, we've reduced the size of the dial, and we do not need to use a speculum with this for sure. Yes, in deep set eyes, it is slightly difficult. So then, I've not tried it with so many deep set eyes, but we can anyways put a speculum and then mark it again. But in normal eyes, sir, I've not faced any issue.
Why do you need a dial? All you have to do is the reference mark, because once you have the reference mark, then you can use a Mendes marker
Yes.
on table. So it's
Uh,
mainly the reference mark. So if you for the reference mark, you don't need a dial.
Yeah.
You can just have two prongs, so it becomes very slim.
Absolutely. So that is one point. Reference mark. Also, I wanted to give it a slight more addition and give the rotatable dial also. So this thing is basically detachable, if you see. So what we also have a similar one with only the reference mark. So so when we are want to give it out with both the things, one is with only reference mark, one is with the rotatable dial, whatever the doctor is comfortable with.
Okay, thank you.
A very good innovation, Neeraj. One question I want to ask, and this applies to a lot of people here who are presenting in these kind of platforms. You mentioned about the patent.
Yes, sir.
One thing about patent is if you present your work
Yes,
in an open forum, which can be recorded,
Yes, sir.
your patent will not get accepted.
Okay.
So be very careful about this. Please do not. Sir is there. I think he's the best man to comment on this. Wherever it's a public forum,
Yeah.
and any one of you have not patented this, and if you feel that you want to patent this, you will get your chance next year. Please be careful, because you cannot go to patent office and the first thing they're going to ask you is, do you have it in any open forum? If you say that I've published it, I'm in ASCRS video.
Moment you publish it, you cannot.
Not even in
Sir,
videos, sir.
Although, yeah, videos
Sir, it
anywhere,
is,
any.
If I can just add, it is published in Indian Patent Journal. It is in the final stage of hearing. That means
No, I'm
provisional
just not for you. I'm
Ah,
telling
yes,
you for
yes.
everybody.
Yes.
Yeah.
If you're, because this is something which we do a big mistake in India, that we present first,
Yes,
and
absolutely.
lot of AIOS is already recorded.
Yes, sir. Yes.
So it is, and if you just type your name, it will come, and they say your patent is lost.
Yeah. In just
Good
before
suggestion.
granting patent, they actually do the final search.
Final search. So this is a take home not for you, for everybody.
Very good suggestions. I'll remember this next
So
time.
if anybody here feels
In
that
fact,
this,
that should have been advised to you by if you had taken a patent lawyer
Yeah, so
in your application process.
The patent lawyer told me that now, sir, this is published in Indian Patent Journal. Now you can go and present.
Okay,
That's what
maybe,
he told me.
maybe. Sure.
That's
but
what he told
for
me.
anybody else, if you have a critical thing, you will get a chance. Probably will win, but please do not do it and expose yourself, because you can't put patent. I think Matthew is aware. We've done these mistakes in the past.
Thank you for the suggestions. I'll definitely.
Yeah.
Absolutely.
Sir, but one thing good about patent for the youngsters is, tomorrow if he wants to get into different innovation, if he has to apply for a government grant, there's a full section of have you
Wait one
patented
more day, you
anything.
will get that.
Even if it's a junk patent, you still have a better chance of getting an award.
Yeah, patenting is
I've spent enough money.
is fairly
But
expensive.
sir, thank you for the suggestion. I'll
I
always
think we'll
remember
move
this.
on
Yeah.
to the next.
I have a question, please.
Yes, sir.
What steps are you taking to ensure that the patient is properly positioned on the slit lamp? Because this will give you the marking 0, 180 or whatever axis.
Yes, sir.
But
First step is lateral canthus should be marking to the mark of the slit lamp. First step is that, most important. Second step is there's a small dial inside. which basically align. So if you make a 0 180 through the dial, you can see the 180 acts as a Purkinje's images. So then we come to know that patient is looking at bang on straight, he's not looking left or right. And through the slit lamp, you can actually go and mark, just like you do an applanation tonometer. So this is how these are the two main steps. If there are any more, so please let me know. I'll be very happy.
So, great. Thank you.
Thank you so much.
Thank you, Dr. Neeraj. We are now going to be having two presentations back to back by Dr. Prasanna Venkatesh Ramesh. The first one would be 3D printing ophthalmology related models for enhancing learning through concept of puzzle assembly.
Yes, sir. Thank you for the opportunity. And I've used 3D printing for pedagogy. So this is something that is least explored in the field of ophthalmology. And 3D printing has been expanded into many different aspects of ophthalmology. I thought, why not we use it for pedagogy? Because when we search textbooks or other things for a cavernous sinus, or these are all undissectable structures like circle of Willis, which I'll be sharing to the judges and the panel here, which I'm holding in my hand, and even the eyeball for that matter, as a puzzle. Can you print 3D models which are undissectable in the field of ophthalmology in a cost-effective manner? That's what we really wanted to explore, because 3D printing these finite structures is very difficult because it tends to break very easily. And can we have a tactile learning possible? So this is the final 3D circle of Willis model that I am having. So this is the cavernous sinus puzzle model I am having, and then I have an eyeball model along with an angle. So toys and puzzles, I got this inspiration from my daughter. So when she was playing a puzzle, can we really make something like this in ophthalmology, which will help cognitively the neophytes train better? So we did read the anatomy in Chaurasia, in Cunningham's. Then we had to make sure we have the anatomy in 3-dimensional orientation in our mind. The ophthalmologist had to sit, and then we had to digitally draw the anatomy because it's not like a 2-dimensional picture. We had to work on the anatomy, and we had to devise every structure for the way it is. And this was a prototype model, and this was a second model where you can see the curves are much better in the circle of Willis, which I'll be sharing to you. And FabX Excel printer and FabX Plus printer was used, one for the bigger model and one for the smaller model. And polylactic acid material was the one that we used to print these models. As you can have the eyeball model. Yeah, so this is the 3D printing of the circle of Willis, and you can customize the color accordingly. As per the structure of choice, if you have a circle of Willis, you want to make it red. If you have the venous system, cerebral venous system, and you want to make it blue in color, they're all possible. So these are all, when we browse the literature, 3D printing was explored for so many aspects in ophthalmology. But for undissectable structures which are very complex, even the eyeball that we printed, you can see it is assembled and disassembled. We used polylactic acid for the sclera and the choroid that you are seeing in my hand, and we used thermopolyurethane for the retina that you can see, which is black in color, and I can squeeze this. So this is the eyeball 3D printed puzzle that we made, which can be assembled and disassembled, that you can see in my hand. Because with adequate supports, we can use different fundus pathologies, like you can use a color fundus, you can use a red-free filter, and you can see these are all the collections that we have. A normal, a flecked retina, you can have with this particular thermopolyurethane for the retina. We add this all, and this is more like a pedagogical aspect as well as a counseling aspect that we have explored. And we have also put it into testing, and it's going on well, and it is open access. We have filed the patent, and we have got it, and this is open access. It's available in www.meh.org.in. It's open access in our website, because if anybody wants, for the love of teaching, I didn't want to monetize it. If anybody wants to download and then print on their own, they can do it. Or we have our own startup called the Mahatma Center of Moving Images Private Limited. It goes by the website www.mcmi.in. It's a full-fledged startup and a department of the Mahatma Hospital Trichy that we are running. 200 rupees for circle of Willis, 200 rupees for cavernous venous system model, 1000 rupees for the eyeball, because it is the puzzle. But the duration takes a slightly longer for the eyeball model. And currently we are in this phase where we are trying, and this is also, you can see, we published this, and we are also writing a chapter on this as to how step by step we went ahead creating this. Puzzle making, when combined with 3D printing, can evolve into a different level of tactile learning. This is the model that currently we are working on. Can we wholly print the brain itself as a puzzle, and like a Batman and a Superman toy, can we give it so that the neophytes, the first year postgraduates or the undergraduates, have a good experience? Thank you. And this is the angle also. The angle is also printed. I'll just forward it to you. Angles. The juxtacanalicular, the corneoscleral, and the meshwork, the 3 trabecular meshworks, the pore size reduces.
One question is,
Yes, sir.
I mean, innovation point of view, I have no doubt about it. It's great one. The question is, lot of us now have more than holding it. Now everybody is going on a virtual, headset display thing, where you can enter into the system, enter into any parts of the brain and all that. So do you think that I mean, this looks good, but practically a headset based 3D viewing system would be a much better way to look at these kind of things than printing it, because whatever you give the 3D printers with whatever materials, it will print, but the usability is what I want you to defend here on.
Yes, sir. Ironically, actually, I went and innovated the headset for the first, sir. Actually, that is part of the second presentation I'm going to have today. So the thing is, the headset was one which was done. The feedback that I got from the teachers in ophthalmology is when I use the AR technology, we are doing extensive work in augmented reality for the past 2-3 years. But the feedback that we got from the teachers, accessibility wise, when we were not able, HoloLens was something that was not available on a multiple level in different platforms. We were able to do it on a smartphone, which I'll be telling. So they gave this feedback that can you give something which is cost effective for us to touch and feel, and maybe we can have it in our museum. So that's why we invented the technology first, and then we went to the Stone Age. It was actually a reverse innovation. So
Great, interesting from a teaching perspective point of view. Absolutely, a touch and feel really does give the novice a better approach to the. Of course, a better advancement would be when, as you were saying, fitting the puzzles together.
Yes.
So, building the brain from the brainstem. So you show the 3 levels of the brainstem components, and you add the cerebellum to it, and then you
Yes, sir.
add the maybe the internal white matter connections, and then move on to the cortex. So that way, and then add the venous sinuses and the arteries to it. So that would assemble and deassemble. So it comes like a puzzle. A person learns so much more. So currently you're just seeing the venous sinuses separately. So you have the
Yes.
venous sinus picture or the arterial system. So while it does help in a sense to touch and feel, but a good image also, especially as the image can be nicely labeled,
Yes, sir.
would give me a lot of information. So maybe we'll also look at your 3D
Yes, sir.
and try and see how both of them
Yeah.
can complement
Each other.
understanding. So you feel at one end, and maybe
Just to add
also
2
get-
points on this, sir. One is
he has another, then we
so one is the packaging of this particular thing is done just like the toys that we pack for the Batman or the Spider-Man. We have used toothpicks and just like a top of the candle. So the anterior-communicating artery or the anterior cerebral artery, so they can just be inserted. So that's how we have done the packaging, but I have not brought the package as such. We have brought the models. So yes, so that's what I wanted to add. And when we went for the review of literature, basic sciences were so just not printed, and we had to do the reverse innovation in the other way. So if it's okay, I can move to the next one. Can I have the next?
Yeah, so we'll have the next one. That's
Aji, come here.
innovative, self-built, cost-effective, and patent-protected
Don't start it. I'll tell you.
4D holographic ophthalmic metaverse.
Yeah, so this was the prior innovation actually. The innovative, self-built, cost-effective, and patent-protected 4D ophthalmic metaverse. So I had this inspiration from Robert Downey Jr. from Iron Man. Can we really work on augmented reality, mixed reality, extended reality? Yes. It was no more a science fiction, my dear friends. This is my dear colleague demonstrating the K-sheets, the EMR that we have at our center in the 4th dimension. You can see a NTG glaucoma being demonstrated with this headset that my colleague is going to demonstrate at the end. You can see the angle structures beautifully, the fundus. Even this patient is having a retinal nerve fiber layer defect. So this is the innovation that we did priorly, where we use the touch sensation in the 4th dimension. Even there was some feedback like the AR headset is quite limiting, where we are not able to buy. We went ahead and did this in the smartphone as well, and this is the patent filing that we did. As simple as a smartphone, today you can walk out with the QR code. This is the QR code. We also made sure we used subtractive learning. So these are the buttons that you can see on the bottom. You can select buttons that you don't want to. You can remove structures. For example, if you're going to operate on, you can choose structures that you want to. You can tone your skills in 3rd dimension using for better dexterity. So this again you can see it's called the 3D subtractive learning, which is currently not available in any apps currently. differently. You can choose structures, you can add structures that you want to. It's also useful for tactile virtual dissection, and this is real cutting edge in augmented reality along with mixed and extended reality. All the three dimensions together. This is one app on your smartphone. Can you get my phone? Yeah, in your smartphone today you can walk out with this QR code. It's called IMG Max in the App Store. It's open access offline app. This is a subtractive learning along with augmented reality that you can see, which is available in your smartphone. We have used a LiDAR scan technology, and this can be there. You can see all the. We also worked on a 3D simulator for a neophyte that you are training. You have to use your right hand and your left hand parallaxly. You can see that he's moving his phone towards it. He's going into the retina. So this gives you a three-dimensional hand-eye coordination development. Not only for this, we have worked on an MAGS simulator. Currently, we have almost cracked the SACS simulator as well, and it can also be used not only for pedagogy and counseling as well as for simulations as well. So these are the current models. The unique feature of our model is we have used real-time confocal images of the fundus and the angle structures respectively, along with filters such as ultrasound, UBM, you want an ASOCD, all these can be added. So the template making was more or less the same, but we had to slightly make sure we had to orient the templates in a much different way, and we started collecting the models. And this, you can see, my dear friends, is one of the counseling stations which is very active at our center. We do a YAC PA or we do a NTG counseling. You can see these videos where we show the patients their own images and we counsel them accordingly. So this is a red-free filter of the same. You can see a beautiful RNFL defect. We advise the patient. So this is the workflow. A patient walks into our center. The imaging, ours is a translational software. You can do how many imagings you want. It goes into the hospital database. You have a translational software, and we have also incorporated the fundus along with the OCT, where you can extrapolate the OCT out of the fundus. And as you get it ready, and you can extrapolate and then show it to the patient, treat the patient. Again, you can see we have these counseling stations in a eye suit where we show the patient exactly the attenders and even the anterior segment imaging. We have also devised this, and this is published in recently after the patenting and everything, European Journal, after the validation on top. So this, my dear friends, we call the ophthalmic metaverse, the 4-dimensional metaverse with the QR code. You can get it today, and this is my team behind it. I would also like to thank my medical officer, Chief Dr. Ramesh, for supporting this project. And now you can see the demo here. Can you show the laptop to the judges? So this is my dear friend here. He is actually demonstrating through thin air. So this is extended reality where he is actually holding it. First, he is demonstrating the normal anatomical structures. If it misses, we have to refresh the button. So again, can you do the MAGS simulator? So now we have worked in surgical simulators, pedagogy, skill-based training, subtractive learning. We have made sure we don't leave anything else. When we read in a textbook, we don't want to miss out on any particular thing. We want to have only 3 structures. Those 3 will be there. We can choose it accordingly.
You cross 4 minutes, you would lose.
Thank you. Yeah, so questions. So you sticked a lot of the original questions that we had on patenting and publishing. Yes.
Have it, no? Have it here.
So essentially, this is a tool for teaching.
Yeah, sir. Yes, sir. Teaching clinics and surgery. Yes.
Surgery, in a sense, how would it assist in a surgical skill training? I mean, I can understand as a teaching tool. Yes, it gives us a very immersive understanding of the anatomy and the structures, and that's
so
great.
Yes, sir. One is a microsurgical point of view. When they experience the structures in a 3rd dimension, when they are taking a suture or when they're taking a simple sclerocorneal tunnel, we have it all ready. For want of time, I'm not going to go into that by demo. So this gives a hand-eye coordination by toning their skills. They can use their left hand, they can use their right hand, and it at least gives them an orientation from a neophyte point of view. So the basic orientation, the microscope orientation.
Your tactile sensation will not be present here.
So there is a small snap which is available in the HoloLens at the ear. When you touch it, you get that small snap that gives that slightly mimics when you touch it.
Yeah, but snap is a pseudo tactile sensation.
Yeah, pseudo, yeah.
But the question I want to ask you is, why did you call it 4D? What is 4D actually?
Sir, we
4D means also tactile, right?
Sir, it's actually in reality it's a pseudo 4D, sir.
Exactly,
yes.
Because it cannot be. Because it's okay, but it cannot be called a 4D until unless you have a tactile things. Your 5 sensation is not felt.
Understood,
so that is something which you have to really look at. Careful, it because
yes.
because it might have a line up in challenge. The last one is when you have such original work published in IGO, you have published in EGO. EGO is impact factor is 1.2 or 1.1, and now we have 3.
I'll definitely correct.
So he's looking at the European market, which will give his returns in euros instead of rupees.
So no Europeans read those papers.
Sir, with better wisdom in the future.
So very important learning. The most important is that trust your IGO. That's a very good journal with great impact factor and an open access. I mean, you'll struggle to get papers being read in the EGO as compared to the IGO. You just type and you get. So of course, that aside, I mean, like I said, I'm like impressed by the educative tool in this. But when it comes to training and all, the absence of tactile, the size differences, all those things would seriously limit the learning as far as that is concerned. But great, I mean, amazing. I mean, I think long we have not incorporated tech in our daily.
If may I add on, sir,
Yeah.
we are currently working on the biometry incorporation. We are working on the sizes of it, and we are also working with the Heidelberg, the fovea BMO axis, how much degree the fovea is below the optic disc BMO center, as well as the biometry for customizing each size separately. Yeah, thank you, sir.
Have you given it to students actually for learning and got their feedback as to whether it is useful? How many of them would use it? How many of them would purchase it?
Yes, sir. Actually, ours is a DNB teaching center, sir. So we started by working with them, and then that's why we understood HoloLens was quite costly. That's why we had to make the innovation in the smartphone as well. In the smartphone, you can have a table stand. The models will come. You'll have to click the instruments button, and then you'll have to take it like this.
How many of them are using it?
Sir, actually, for
the discussion allowed is only 2 minutes.
Yeah,
we have
I
a
think
next
we
session.
have
PG
gone through.
thesis here.
Thank you very
sir.
much.
Thank
We always look forward to new and interesting things.
Clearly, only one judge should ask, and only for 2 minutes.
So we are next to
Because,
Dr. Subendu Boral.
PG thesis has to be done. After
He
that.
is going to speak on micro VFC, a simple
indigenous
access subretinal space in controlled way.
Good afternoon, everybody.
new tool to access subretinal space in a controlled way. VFC, that is viscous fluid control, is commonly used in vitreoretinal surgery to inject silicone oil within vitreous cavity or to extract it in a faster way. We developed a simple indigenous modified VFC to gain access to subretinal space in a controlled way. We have removed the plunger, cut the rubber cap of the plunger of a 1 ml syringe. This cut rubber cap was fitted inside an empty 1 ml tuberculin syringe. Its end was fitted with the tubings of VFC of vitrectomy machine. Now VFC mode was activated. Attaching an either 38 gauge or 41 gauge subretinal needle to the syringe to extract the retained submacular PFCL bubbles or to deliver precise dose of subretinal drugs like RTPA for subretinal hematoma in a controlled way. Here the cut rubber tip of the plunger can move smoothly within the 1 ml syringe during injection or extraction mode of the VFC. We named it micro VFC. Firstly, the practical application for extracting the subretinal retained PFCL bubbles. Here it's a case of status post-vitreoretinal surgery with a retained subfoveal PFCL bubble with best corrected visual acuity 2200. I used our micro VFC using metallic tip 41 gauge cannula. After extracting the silicone oil, I went ahead with this micro VFC. I directly pierced the fovea with the metallic tip and made the extraction mode on with around 300 to 400 psi to aspirate out the PFCL droplet. Fluid air exchange was completed. Post-op best corrected visual acuity was 2080 with complete absence of subfoveal PFCL bubble. In our second case, post-surgery for giant retinal tear, there was a large bubble of submacular PFCL threatening fovea with best corrected visual acuity 2060. After removing silicone oil, I used this micro VFC with 41 gauge metallic tip cannula to remove the submacular PFCL bubble. Using viscous fluid extraction mode with 400 psi extraction pressure, PFCL bubble was extracted completely. Postoperatively, best corrected visual acuity improved to 20/40 with complete absence of submacular PFCL bubble. I also use this micro VFC for delivering drugs in subretinal space. Like in this case of post-PCV massive submacular hemorrhage with best corrected visual acuity, hand movement close to face. Here I used our VFC with 38 gauge non-metallic cannula for injecting recombinant tissue plasminogen activators 0.05 cc, that is 50 microgram, directly into the subretinal space through a mostly elevated area just outside the macula for clot lysis. The subretinal injection of RTPA was completed in a very controlled way. Again, I have used combination of anti-VEGF ranibizumab injection 0.05 ml and filtered air 0.03 cc and injected slowly in subretinal space outside the macula. Then I completed fluid air exchange and used sulfur hexafluoride gas tamponade. After 3 weeks, best corrected visual acuity improved to 20/120, significant reduction of submacular hemorrhage with CNVM remnant only. So this indigenous micro VFC can be used for both extracting subretinal PFCL bubble or delivering the drug subretinally in an exact dose as well as in a very controlled way. It can also be used for further transduction of subretinal gene therapy. Thank you.
Thank you, Subhendu.
Thank you.
Lovely videos also. Yes, Dr. Guru Prasad, I think you could.
We also use a similar syringe which is commercially available. I don't see any difference between what you have shown in the video and what we have been using. I think from Med1 or so, they also make needles, micro tip needles with 41 gauge tips and 39 gauge tips, and they also provide the syringe, which is almost similar. But of course, yours is do it yourself. DYI.
Do it yourself. Basically,
yours is DYI. Yeah, you cut the syringe and
that rubber cap only that is snugly fitted inside this 1 ml tuberculin syringe, and it's moved so freely, and so that you can use the exact dose of the anti-VEGF or RTP or any kind of drug that you want to deliver subretinally.
Right.
Where is it? Which one?
And for the subretinal PFCL removal also,
Yeah, there are so many indications apart from PFCL removal, which is the commonest setting for RTP.
It is very useful.
Injection. Yeah, it is. Yeah, air nowadays we don't use RTP anymore. We're using just air, and it works very well.
Yes.
Thank you, Dr. Subhendu. I think no more questions. Thank you, Dr. Subhendu. We'll just have one again misalignment before we go back to our original order. We'll have Dr. Jitendra Jithani, who will be talking about measuring peripheral refraction.
Thank you, sir. I will be speaking about one of our simple innovation that we did for this patient. I will just show the patient and we will start. So this is about a young boy presented to us with myopia. Post-COVID, he had a refraction of 1.25, 1.5, which was simple myopia. We did all the investigations that we normally would do in a myopia control clinic. We did their axial length, we checked their NPA, did the orthoptic examination. Stereo acuity was good, cover test was normal. So we moved and asked them to come back again after 3 months. So as it happens in pediatric ophthalmology, once you give glasses, they don't come back after 3 months. The patient came back after 6 months, and there was an increase in glass power. We promptly did axial length. It was axial progression, so we started him on low concentration atropine. Patient still improved, still progressed despite using low concentration atropine. From our own experience, we put them on increasing the frequency, and clearly the patient was a non-responder and the patient was still improving. So we had to do a peripheral refraction. Now we all know how to do a peripheral refraction. The problem statement is that this particular device, which is an open field autorefractor, is little out of budget for us. So we presently also do not have an open field autorefractor. So we thought that we will try out our own solution. So this is a schematic diagram I made on my own, and then I got it 3D printed. So what we did was we tried to make a simple peripheral refraction aid, that is what we call it. It can be fitted on a hind retinoscope, and it has 2 arms. so we have measured the distance, and it has 2 arms, and they are exactly at 22 degrees when you sit at 67 centimeters. So we have to sit straight in front of the patient, and then we have to tell them to fix on either point. There's a wonderful article which was published in 2008 which says that whether you turn your head or you turn your eyes, the peripheral refraction remains the same. So, but here we are just trying to show that, you know, we told the patient or told the subject to move the eyes on either of the points. Now we can have an object behind us also, but the problem is when you try to do the nasal refraction on the right eye and temporal refraction on the left side, the object is right behind you, so it is very difficult to do that. Whereas here, both the fixation objects are right in front of you. You are holding the retinoscope, the 2 markers are right in front of you, so it becomes easier to do the peripheral refraction. And rest is all simple. This is all proven how peripheral refraction helps or aids in knowing that whether the patient would progress in myopia or not. So this particular patient, we did peripheral refraction. It turned out to be hyperopic, and so we prescribed the Stellest lens, and we could see that in next 6 months the progression actually slowed down. And in April 22, that was the last follow-up, we had a refraction of -3. So this was a small device which helped us in finding peripheral hyperopic refraction, whether it was there or not. This is just an algorithm of how we treat our myopic patient, nothing much. So thank you so much.
Thank you, Dr. Jitendra. Excellent innovation. Any questions? My comment is, are we actually finding solutions for problems that probably do not exist at the moment, and we are like creating a problem and providing solutions? So we don't know whether peripheral hyperopia is definitely kind of cause for progressive myopia in these children, and obviously then appropriately is this the solution. But like I said, peripheral refraction is something that is now getting in vogue.
So
as you
peripheral
mentioned.
refraction is nowadays it has becoming. It is sort of need of the hour of people who are practicing. You are definitely trying to get a open field auto refractor. Sir already has it. So this is something which has come up, and this is a frugal, easy solution to a costly treatment.
Absolutely.
Is it any?
So weighing the, separate, if we weigh the instrument per se.
Any specific age group that you have tried, or it's a blanket, whomsoever you feel there is a progressive myopia, you do up this thing, peripheral refraction, and evaluate whether there is a thing.
So the aim is to do my point and my aim is to do peripheral refraction in normal population, myopic population, and find out. All this is already available, not for Indian population. There's a good paper by Pawan Varkicharla from LVP where they have said that there is a difference in nasal and temporal peripheral refraction in Indian eyes, whereas typically in Caucasian or other studies they have said that there is peripheral hyperopic refraction in myopic patients, whereas they have not found it in Indian eyes. But that is the only one study right now from India.
What age group of children would cooperate for this testing?
So I think as a pediatric ophthalmologist, it becomes easier to work up with a retinoscope because this is day in, day out, we are using a retinoscope. I would say it would be difficult to put them on a autorefractometer, open field autorefractometer, and to tell them to look at the chin and do the autorefraction. It would be much easier to do a retinoscopy because retinoscopy we are so in tune with a retinoscope that once we know that he has got in center like -3, we can immediately tell whether there is a hyperopic refraction in the periphery or not, because you can see that he's neutralizing in the center point and whether he still has the width movement in the peripheral point. So it's much easier, and what we are actually looking at it is just plus 0.75 diopter of hyperopia. So that much we can easily make out even clinically. This is for the documentation, but even clinically we just need that whether it is more than 0.75 or not.
Jitu, why have you kept the 22 degrees angle that you said specifically? How does it help?
It becomes very long if we keep it an angle. If we keep it straight, we tried out multiple designs. This is not the final design. There's another design also. We have tried to elevate it because with the retinoscope head, he has to look slightly down. So we have tried to put an angle on it, but because if we make it straight, it touches you can't do it. So that it's ergonomic. That's it.
Thank you, Dr. Jitendra. We'll now go on to back to Dr. Prithvi Chandrakant. I think Prithvi has two presentations. So his first one, the slit scope, is the one he'll be presenting first. Okay, so Dr. Prithvi on the slit scope.
दूसरा
Good afternoon, everybody. No financial interest and no conflict of interest. As we all know that in India, as we all no conflict. Yeah. So as we all know, in India we have a lot of outreach programs where we go and check for cataract, and the only way we can do that now is with the torch. So we grade the cataract with the torch, and there is no other replacement or replicate to replicate the slit lamp. So it becomes very difficult because we cannot actually take the slit lamp every time everywhere, and it could actually damage the slit lamp, so it is very inconvenient. So what the problem statement over here was whether we can replicate something like a slit lamp. So we came with the solution that there should be three things involved in this. One is magnification, one is slit illumination, and imaging device. So as we know, we have already found a solution for the magnification and imaging device. One is the imaging device, the smartphone, and the magnification is ASP, that is anti-segment photography with intraocular lens. That is basically a chart paper within which a double-sided tape is attached, and an intraocular lens from ranging from 15 to 25, any of them according to the magnification you want, you can actually stick it inside, and once that is done, you can stick it to the smartphone, and then you can use it as a magnifying device. The other problem was the slit illumination. So for that, I introduce you with the slit scope. These are my co-authors. The slit scope is actually basically done. So what we did is we opened up the slit lamp and saw the basic optics of it. So it had a LED light, a slit opaque disc, and then a magnifying lens. Over here we use an intraocular lens again. So we use the same principle, and we made a slit with a chart paper, and then we used a small the marker old marker pen which we sliced open and fit into the torch light, and then a intraocular lens which was kept above. And once that was done, we could actually get a proper slit image of the light from the torch. So this was then so I used it on my own eyes, and we can see over here. But over here, the actual slit was a little thicker because the paper slit which we made was a little thicker. So this was done basically without a slit lamp. So then we thought, why not make it more stable like an adapter, and we started using it with a 3D printer. So here with a 3D printer, we were able to make small adapters like this, in which we can actually change all the shapes. We can have a square or circle of different diameters or different millimeters, and also a slit, as you can see over here. So this came to me with the torch. It actually costed me around 350 rupees. So this has become a very simple way of making a slit. And now, along with the ASP, we can actually take images of the eye without a slit lamp, which actually gives equally good amount quality of images with the slit lamp. So over here you can see immature cataract with PXF. The other one is a multifocal IOL. Over here you can see corneal scar with pseudophakic eye, blue dot cataract with sutural cataract, and all these images were taken with the ASP and the torch alone, and not with the slit lamp. Where you can see a brown cataract and a mature cataract. So the main I would like to conclude that in places where there are no slit lamps and there is a need for a slit, and we can actually use these very innovative, very easy and cost-effective do-it-yourself or 3D printable things to examine and get images. Thank you.
Thank you, Dr. Prithvi. Any comments, questions?
Dr. Matthew, why you quiet? Simple and interesting. Very practical.
So the
Yeah,
two
you go to the
devices
hand
you are
and
holding
put it
in your hand separately.
You don't need a
What is the grade of the cataract?
He doesn't have cataract. He's a young man.
Again, any questions?
Basically, you have to hold it with your hand, so it's not very stable. So if you can have something like an arc where you can fix it and move it around, then you can get the slit at various positions. And also you should
need
be
to
able
have
to change the width of the slit. If it's a fixed slit, again, you can't really, it's limited. You have to put in different caps for that. How do you do a retroillumination?
Come on.
So it's a
it's a very good innovation.
It's in process of development, but sure, whatever stage it is now, we need to assess that at its value at the moment.
I think most of us have that peripheral vision centers, so I think it's good for the optometrist, at least for the
Camp setups and all that.
Work by the technician also, because an image has to be captured, nothing more than that. If he is good in that, it can be utilized. And you have various slit size, that is what you said, that you're going to provide with this. So very nice. Thank
Great.
you.
Any question, or we'll have his next? Okay. Anything? So we go on to his next presentation. So Dr. Prithvi would be now
How many?
presenting his gimbal scope, his second one. We have three more. Three more after this. So Dr. Prithvi on the gimbal scope. Four.
The next person should be ready. Call
Yeah.
the next three names, no?
Yeah,
So that
they
are
all
ready.
know. They are there. They are all loaded.
So I'll be talking about
Hirika,
the gimbal
you are
scope,
next.
no financial interest, no conflict of interest. Over here we can see that retinoscopy, as we all know, from your residency onwards,
Yeah,
it's
this
always
is
a
the
mystery.
second.
We always
Then
have a
Hirika.
problem trying to understand what the reflexes are, and especially when we are in our first year residency, it becomes very difficult for us to learn the art of retinoscopy, and it's very skill dependent, and there is no live demo of the actual reflex that we are seeing. So when the mentor says that you have to see with the moment or the against the moment, it becomes very difficult for the first year residents to actually understand, and there are no video libraries, and we all have to use a schematic or a model eye. There is no live demonstration of the retinoscopy reflex, and it actually becomes very difficult, like you see when we have to tell them this is with movement of reflex, and they have to come and sit there and they have to try see it again. So what we were thinking is, why not innovate something which will actually let the students see the images right there, live demonstration of the retinoscopy reflex. So we thought about smartphone, and then we thought about a gimbal. Gimbal is actually a smartphone stabilizing device. So we use that concept and we try to put that in the retinoscope, and that's why it's called gimbal scope. So as you can see, it looks like a gimbal as well. So we use this over here. I'll tell you how to make it. So we use a super glue to attach all the adapters, the rubber bands to attach the adapters, and then attach the smartphone to the retinoscope and the adapters together. Over here you can see these adapters are attached together, and once those are done, we put it onto the retinoscope. Once we put it to the retinoscope, the smartphone is attached to the adapters. So once that is done, we can actually take images like these. So these are all video recorded images which were not previously recordable. So this is we used to only have animated images, but now we actually can take live images of the retinoscopy reflexes, and it becomes very simple and very easy, and actually reduces the learning curve for all our residents. Over here we can see the scissor reflex demonstrated beautifully. So although we made this gimbal scope, there were limitations. One was initial assembling learning curve, a small learning curve was there, and it was to be heavy, and the focusing sleeve was difficult to approach because you have the smartphone. So what we did is we 3D printed a small adapter, which would actually 3D which actually goes on top of the retinoscope, and then we have a small endo camera which will actually help us take the video to our phone or the laptop. So this is the arrangement, and this is the adapter which could actually go onto the retinoscope here. So once that is done, the endo camera is attached to it, and then we get a live feed of the retinoscopy reflex exactly like how we saw onto a smartphone or the laptop. So gimbal scope is a very do-it-yourself or a 3D printed frugal instrument which can be used for live demonstration of all retinoscopy reflexes, making retinoscopy more easier for the residents. Thank you.
Thank you. I think an excellent innovation. I would say that something, the art of retinoscopy, that is very quickly disappearing, and it's something which is very difficult to teach. Obviously, as you pointed out, it's very difficult to show the reflex to somebody. You can see it yourself, and then you assume that the next person is seeing the same thing. Yes.
In the
Dr.
first
Dasu.
part you showed was with the mobile camera, and the second part you have to have a laptop to be connected.
Dr.
How do you do
Hirika,
it?
you can just come up and be ready so that.
Okay.
Just take a mic so that the others also hear what you're saying.
Connected to the phone. Once you connect to the phone, so you can take these images.
Sorry?
Yeah, but you need to have that application. So if you have that application, that's free downloadable application that we this one,
Okay.
this company is. So we have different companies which manufacture these endo camera, which you can buy from Amazon. It hardly costs 1,000 rupees, and they give a manual for each company. They have their own manual and QR code which you can download from the app store, and you can take the images. So this is actually used for engineers where they want to go inside the computer and check for all the instruments if it's fine. So we are using
Great.
that one over here on the 3D printed thing, which will be attached here, and then you can get live feed of the.
Great. Thanks. I think we'll go on to the next.
What is the total cost?
The cost for getting this 3D printed is around 150 to 200 rupees.
No, the net cost should be of the entire, the whole thing, na? Because the person will have to, so the whole cost of the.
Around 1,000, 2,000 is
Yeah.
the total cost. Is very good, nice, innovative product.
Sure,
Thank you
exactly.
very much.
Great. Dr. Hirika is going to talk on iLog, a perfect surgical digi logbook for every resident.
I'll be talking about a surgical digi logbook. So let's all go back to our first day in the OT, our first cataract surgery, and what our trainers actually commented. And taking in all the feedbacks, your tunnel wasn't good, your side port wasn't correct, your rexus wasn't correct, and you should do wet lab practice. So yes, obviously we cannot forget those days, and the most important question here is how did we perfect those surgical steps and how did we tackle those complications? So talking about me when I was a first year, the prototype, like what my mentor told me, was to actually make an Excel sheet. So I use the numbers app on my iPad, and I used to log in all the patient details from the demographic data to the surgical type, which either surgery was, what was a pre-op vision, what was a post-op vision, the complications faced, the assisted steps, who assisted me, and for what steps. So that was my journey during my training phase. And initially I was having a lot of complications, and slowly, because of the logbook use and reviewing back on those cases, I actually realized that it actually helped me reduce the complications, and over a time my complication list was equal to nil. So and also we were asked to do the ICO Oscar grading. So what we did was printed those sheets and asked our trainers who had watched our surgeries or the surgery videos to mark us according to the steps. So as all of us know how the Oscar grading grades you according to each step, from the draping to the tunnel to the entry to the rexus to all the steps, the IOL insertion. So I realized this was actually a very tedious job to record all the surgical data. The trainer cannot actually moderate you. It is very difficult to review everything at once. So this hackathon that was held in Arvind Eye Hospital, Pondicherry, I came up with the solution of Scrubbook. So this is Scrubbook. So it is a web page app. So here you can see how the trainee can actually make an employee ID, and then he can add all the patient details from the EMR, if you have a working EMR in your hospital, to the age, the gender, the type, the date, the place of surgery, the type of cataract, not just cataract, you can add PXF, you can add small pupil, all the extra things. You can add posterior segment findings to actually correlate if the vision was not due to the anterior segment but due to the posterior segment finding. And then the pre-op vision, post-op astigmatism, pre-op astigmatism, complications. You can add your surgical Google Drive link so that the trainer can actually access it, and the assisted steps and all the necessary other things. Then we also have a trainer login. So one second. So the trainer login, he can actually, the trainer gets access to the trainee. So he has to mainly know the trainee's employee ID, and he can actually grade the trainee looking at the videos online, or if he's seen the surgery, and give him the exact score over in the same app. And the trainee can look at it and he can know what the trainer has thought about or reviewed about his surgery. He can add comments about it. So here you can see how it all works. So you can all review it all at once. So it's a handy go-to app for every resident or trainee, which can be used as a digital surgical logbook. A trainee can easily store patient-related data. Patient record can be searched by the trainee at any time. All complications can be reviewed at once. Complications can be moderated by the trainer himself, and further wet lab accordingly can be instructed. Surgical link can be provided. He can do Oscar grading, which you cannot otherwise. I mean, you have to give a printed sheet or something else. And my future prospects for this is to introduce statistics for all complications, an alert notification on exceeding a complication or recurring complications, and taking experts for complication management and to hire expert surgeons. So it's a great app to review complications and pocket friendly. So that's the link if you guys are interested. Thank you.
Thank you, Harika. Any comments on, yeah?
Do you manage to score the technical difficulty of the case from the data that is there?
No,
because
sir.
the complications that are going to happen as a consequence of what
Yes, sir.
the technical challenges were in the case. That has to correlate, otherwise this is not telling
No,
the
sir.
full
So
story.
mainly we have marked, as of now it's a very early stage. We have not. I've not put in that much finance into it to make it that much. But my future aspect is that I want to make it like I'll have I want to color code it in the sense that when there are no complications or there's a complication, there's a rent. So accordingly, that patient can see the stats of the growing graph or a down graph or an up graph on the app, and he'll know. But we, as of now, we are not individually looking into each. We are not looking into the details.
No, your raw data is there because you're choosing
Yes, sir, but
pseudo-exfoliation,
this
deep
is-
socket, etc.
Yes, sir.
So there are validated scoring tools already available in published literature. You
Yes,
just
sir.
need to correlate on one axis the technical difficulty along with the score, and that
Okay.
will also tell you when the person is ready to move to a more technically challenging case, or when to stay back at the current level of difficulty and do more practice at that level.
Okay, so thank
Because
you.
the stats, one of the big USP of this is going to be when you build in a stat. For example, when I was looking at your score sheet,
Yes, sir.
uh, a patient's coming for Undulpet, if I pronounce it right,
Yes.
you had more complications from that area.
So I was no. So that is my training center.
Whatever. I mean, the question is that training center may have a different microscope.
Oh, yes, sir.
And that might,
Yes, sir.
so it helps people
To understand.
why
yeah.
people on Undalpet has more
yeah.
complications. So it might help
Okay.
the institution to change.
Oh, yes, sir. In fact, somebody told me that actually, if we have a lot of residents or a lot of people putting in data, we'll get a lot of data to understand the difficulties. Otherwise, to get in a whole knowledge about what are the other difficulties faced, we'll get a whole lot of data together in one platform.
Yes, Dr. Satya.
Only thing is, I had a little bit of a safety aspect when you're using the app. How safe it is to keep that in the app for the students and then for the institution, because it's all patients' data. Is it possible
data
to
breach.
share that much?
Yes, so
Because,
probably not the names of the patients, but just
But the
it's always there with the MR number, everything is there.
MR number is there.
but we
that makes it
otherwise
an
also have it. I mean,
Yeah,
Yes.
Dr. Shri, yeah.
This is
Yes.
this is very kind of basic, but there are companies which are making advanced tools. Our center was one of the centers where we looked at using AI to train for surgery. And Zeiss has a project, they have an app called the Surgery Optimizer, which uses AI. You record and you can upload it on a cloud using the Surgery Optimizer, and then it breaks up the surgery into different steps: incision, rexis, hydro, okay, and then you cannot edit the video. So it is unedited. You can also compare it to featured videos, your mentor's videos, side by side. You can play it
No
in
sugar.
slow motion. You can give comments
मुझे नहीं चाहिए भाई.
on that particular step.
Okay, sir.
So you
Thank
can actually go back and review what your mentor has commented.
Yes.
So it's already a very advanced app is there,
Okay, sir.
which makes your work very easy.
Okay,
Because
sir.
this is a little cumbersome where you have to enter all the
Yes,
details.
sir. Yes, sir.
Okay. Thank you, Dr. Harika. We'll go on to the next one is Dr. Vivekanandan. That will be followed by Dr. Anjali and finally Dr. Shivraj. So that's the order. Dr. Vivekanandan. His topic is flanges, the Brahmastra for anterior segment surgeons. Thank you.
So, good afternoon, everyone. So today I'll be talking on flanges, why it's the Brahmastra for anterior segment surgeons. So initially it was inspired by Devinder Grover and Ronald Feldman's GART. That is how we got inspired for this. So this led us to the path where we wanted to replace knots with flanges.
काफी बाहर नहीं है यार, बेचारा लॉबी जाके आया.
So the challenges where we use flanges is when we have a large zonular weakness, iridodialysis repair and aphakia management. These are the indications where we prefer to use the flange technique. So this is a case of microspherophakia, where capsule hooks are used, phaco is done, CTR is placed, and to place the capsular tension segment without peritomy, without any scleral flaps, you can pass the needle through the eyelet on the CTS, flange it so that it's becoming bigger than the eyelet itself, and the externalized suture is also trimmed, flanged to the adequate tightness. So this is one indication where we do the flanged technique. And then the other one is, this is our iridodialysis repair technique, where it's a traumatic cataract where the iridodialysis is anchored, kept at bay, and then using a dispersive viscoelastic, the iris is flattened, the iridodialysis is identified, marked, and then using a needle, it is passed ab externo into the anterior chamber through the peripheral iris. It is passed through the peripheral iris, it is brought out through the clear corneal incision of phaco, and the same needle is passed inside the anterior chamber, passed through the peripheral iris, and then ab interno, it is exteriorized. The sutures are trimmed, flanged, and buried. So this is one our way of doing it. And then coming to the flanged scleral fixated IOL, where the cataract is extracted, traumatic cataract is extracted, the needle is interiorized. So what happens is we use a regular PMMA lens which has dialing holes in it. We pass the suture from above to below, trim the suture, flange it so that it is bigger than the dialing hole itself. The IOL is pushed inside. The exterior sutures are trimmed, flanged, and buried. So the main thing that I want to cover is the advantages of flanges is that it has no peritomy, no scleral flaps, minimal sclerotomies, less time consuming, and the learning curve is much quicker. But there are concerns about endophthalmitis due to suture tract infection, flange dislocation, and conjunctival erosion. So our first solution to solve these problems is to move the conjunctiva radially before we make the sclerotomy. So as shown in this image. So the conjunctiva is held along with the tenons, it is moved radially, and then the sclerotomy is done. By doing so, at the end of surgery, we have intact conjunctiva overlapping the flanges. So you can see the conjunctival tract and scleral tract are at different places. And then instead of using the traditional 26 gauge or 30 gauge needle, we designed a 16 millimeter long spatulated needle, which is exclusively for the flanging technique, because it reduces the size of sclerotomy and the amount of suture that is required for flanging. This is a comparison between the 26 gauge, 30 gauge and the spatulated needle. So this makes an incision somewhat like 250 into 100 microns, which is like a rectangular incision, whereas the 26 gauge and the 30 gauge makes an incision which is an irregular circular incision, almost double the size. So incidence of flange slippage with the new spatulated needle is almost zero actually compared to the previous technique. And the length of suture required for flanging initially was around 3 to 3.5 millimeter with the 26 gauge needle, whereas now it is around 1.5 millimeters. And the other last important thing that we found out, that is the amount of force required to do the sclerotomy is much lesser, which is like 46 gram force compared to the 26 gauge, which is double the gram force. This can cause traction with the more force in a vitrectomized eye. So we prefer to use this needle, which reduces that complication as well. Thank you.
Thank you.
Hello. What is the gauge size of the spatulated needle? 140 microns is what you
Sir,
said.
it is actually 150 microns, but when we make the incision, it's not going to be exact. No, while coming out, we might tear it a little bit. So we've done a few in lab tests. It is somewhere between 200 to 250 microns by 120 microns.
Okay.
So it is like a small slit. So
got
compared to the 26 gauge, which we can see that there is a hole on the sclera, this is a small slit which is not visible after puncture and removal.
Just one question about the consistency with which you can actually have this knob or the flange on the sclera or just within the sclera, because what is the size of the knob itself, size of the flange itself?
Sir, the
Secondly,
size of the flange.
the thickness of the sclera and the rigidity of the sclera.
Yes.
So all these matter in preventing it from slipping inside.
Slipping inside.
So how do you optimize
So this
it?
being a slit, sir, it prevents the slippage of the flange. Initially with the 26 gauge, to plug the large sclerotomy, we flange around 3.5 and a little bit over than that. So sometimes what happens is you see a little bit of elevation in the tear film, which was bothering us. That is the main reason we wanted to reduce the length of suture being flanged. So for with the spatulated needle, it is like a small incision. So you make an incision in the sclera and come out, it is very difficult to find where the sclerotomy is. So just 1 millimeter of suture being flanged, and make sure that it is buried underneath the tenons. Then there is no elevation in the tear film. It is just a small dot that we see on the sclera.
In your experience, what is the percentage of flange giving away or getting dislocated?
Sir, with the 26 gauge, we had 2 cases. Now we've done over 300 cases. A few of my fellows are also doing this. 300 plus cases. We had 2 cases with the 26 gauge. But with this spatulated needle, the only problem we had is if your first flange is a little bit tighter, the IOL mild decentration we've had in a few cases. That's the only problem we've seen. Do you go directly perpendicular or do you go at we go perpendicular, sir. But we make sure we move the conjunctiva and tenons radially, displace it nicely, because the flange being very small, we make sure to move that and do the sclerotomy so that intact conjunctiva is over the flange.
Thank you. Thank you very much.
Thank you, sir. Thank you.
Dr. Vivekanandan. So last 10 minutes of this session, we have just 2 more speakers left. I request Dr. Anjali Saigal. So she'll be speaking on a novel biodegradable safe personal protective equipment PPE, which is made up of soap, paper and gauze. All the best, Dr. Anjali.
Thank you. Good afternoon, respected colleagues. And hello. My innovation is a medical environmental innovation, and we have received a patent recently for this. And basically, this innovation addresses the problem of plastic waste, which just engulfs us. It is non-biodegradable and harms the environment as well as all of us. Single-use plastics are 40% of this waste, and about 8.4 million tons of plastic PPE has been generated by this pandemic. And so much so that this pandemic has been labeled a shadow pandemic within the main pandemic.
So our innovation is a PPE made of completely biodegradable, ecologically sustainable material, which is soap paper. The idea came from the soap booklets which travelers take and travel. And these were commercially available only as tiny strips. So we had to actually persuade a manufacturer to make a big spool for us. It was very fragile the way it was. So we then put a double layer, and then we put a gauze lining to make it increasingly durable. And finally, we realized that if it has to be pandemic friendly, we have to seam seal it. So we managed to do that. Over the months, we made many refinements to it in viscosity, flaking, etc. And our objective of making all these refinements were to make it very safe for the pandemic and also to make it durable. This is our current prototype, and it has 3 layers: outer paper, an inner soap lining, and the innermost is a cotton lining. There are several advantages. It is hugely biodegradable, whereas plastic PPE is totally non-biodegradable. Apart from providing a physical barrier, we know that soap is virucidal to enveloped viruses, not only the COVID virus, but also the anesthetists. They keep asking us about HIV, hepatitis C. And the best part is if this is accidentally wetted, in fact, the action gets enhanced due to the micelle formation. If you carelessly dispose this thing, there's no problem because there's this germicidal layer. However, if you carelessly dispose plastic PPE, viruses can survive on the surface of plastic PPE. So in fact, that acts as a big fat fomite. It is more affordable than the higher end plastic PPEs. It is non-toxic, no chemicals are used. And the soap is derived from coconut oil, which is known to be a very good raw material for the skin and is used in various skin products. On the other hand, you all know how harmful microplastics are for the skin. The raw materials used to make this are cheap, they are natural, whereas you know that plastics are made from fossil fuels, which are a dwindling resource in the planet. Our prototype we sent to see if it matches the safety standards of plastic PPE as prescribed for plastic, and indeed it did, and it's ETO sterilizable. I thank everybody who had helped to collaborate with ideas or encouragement on this journey. And now the pandemic is winding down, but still it has a lot of utility because we don't know when things will surface again, what new virus will surface. So that original thought with which it was made to be a alternative to plastic in a pandemic of viruses always remains. And this material actually has a huge wider applicability, not only in this, but in gowns, packaging material, trolley sheets, and a whole range of things. So it could be an excellent way to replace the plastic and contribute to the reduction of plastic waste. Thank you so much.
Thank you. I think, it really, pandemic or not, I think ecologically sustainable medical equipment is, I think, the need of the hour. Any questions? High volume consumers of disposable.
Yeah, I was just going to ask you that only. What about the high volume they're saying? What is the shelf life for this? How long does it stay? The way, whatever the validity components that you have shown, is it true after about a year or so? Because if you're buying in bulk, it's going to stay in your storehouse.
Yes. That's an excellent question, sir. And in fact, we have yet to go towards production. It was in the prototype stage. But just to tell you, the shelf life of about soap everywhere is at least 3 years. The government requirements when you sell something medically is 5 years. If you're selling it for non-medical uses, then you don't need that 5-year thing. And we have to work out for this material, once we go into actual production, if we go in, then it has to be standardized.
It maintains all whatever you have said over a period of time. That is what was the second question, the corollary of the
It can
part
be
of it.
ETO, made ETO sterile. So like anything else, So we have done sent it for bioburden testing. The labs, which where you collect the blood and all that for blood transfusions. So we've sent it to those labs and they've confirmed it's sterile and all that.
Okay, thanks a lot.
On the lighter side, you can get into the shower immediately without removing it.
Thank you.
Thank you.
I think wonderful. It's a very, very important thing, and I think all of us should start thinking about how to ecologically save the environment. So thank you.
Thank you so much.
And
thank you, Dr. Anjali. We have the last speaker of the session, Dr. Shivraj Tagare. He'll be speaking on NIST, that is needle incision subtenance anesthesia. All the best, Shivraj. Load the presentation, please.
Good evening, everyone. I'll be talking about NIST, that is needle incision subtenance anesthesia. So, as we all know, that cataract surgery is performed under topical, either subtenance or peribulbar anesthesia. Topical anesthesia is very widely used for phacoemulsification processes, but as you all know, it does not give akinesia, nor it is contributing to reducing pain sensitivity when iris and ciliary body are concerned. So peribulbar anesthesia was one of the alternatives, but it has been found that there is a lot of chances of subconjunctival hemorrhage, chemosis, and one of the most dreaded complications like retrobulbar hemorrhage, globe perforation associated with peribulbar anesthesia. Subtenance anesthesia has been found to be safer as compared to peribulbar and retrobulbar anesthesia, and can be very well used in complicated cataract surgeries like hypermature cataract, posterior polar cataract, and in associated cases of phacodonosis following a trauma or a traumatic cataract. So the problem statement is that the present conventional technique of performing subtenance anesthesia uses conjunctival scissors, which is used for blunt dissection of conjunctival subtenance tissue. And as you can see, there is a lot of conjunctival defect which is produced altogether in this process, which leads to various complications like subconjunctival hemorrhage, chemosis, and as the size of the defect is larger, it is a possible nidus for infection, and also there is leakage of the anesthetic agent, which leads to decrease in the anesthesial effective produced. So we came up with a solution of using a different device instead of using conjunctival scissor to eradicate the pre-existing complications, to reduce the amount of anesthetic used, and also to avoid blunt dissection of the conjunctiva and Tenon's capsule. So we came up with the idea of using a punctum dilator or the lacrimal dilator, which led out to our innovation called NIST. So as you can see in this video, a punctum dilator, which is Wilder's size 3 punctum dilator, is used to create a nick in the conjunctiva and subtenance tissue. The forceps is used to create a triangular space, and as you can see, a single stab, like a stab entry, can just create a dissection plane in both the tissues, and the viscoelastic cannula can just go into the subtenon space, and the anesthetic agent can be injected. As you can see, the akinesia effect is very nicely seen in this patient. So what are the advantages? As we know that the size of the lacrimal dilator is very small, hence the amount of blood vessels which are damaged altogether in this process is very less. So the amount of subconjunctival hemorrhage produced due to dissection is reduced. Also, we can select a zone in the conjunctiva which is free of any blood vessels. Hence, when we make a nick, when we make a entry into this point, there is no blood vessels which are given damage, and this altogether leads to decreased subconjunctival hemorrhage using our technique. Also, the size of the wound which we create by using the lacrimal dilator is very small, and hence the viscoelastic canal just snugly fits into it. Hence, the anesthetic agent which is coming out is very less. So the entire anesthetic agent goes into the subtenon space, and akinesia effect is produced, thereby reducing the amount of anesthesia which was used compared to that used in the conventional technique. And as you know, more the anesthetic agent it can increase the IOP. Hence, we have found that minimal IOP rise was found in the situations. So to conclude, NIST technique prevents complication made by dissection in the conventional technique of subtenous anesthesia, while ensuring the quality of anesthesia. Also, the post-operative patients have less, they do not have redness or other problems, which gives the aesthetic quality to the patient post-surgery. Thank you.
Very nice. I just would like to ask you what gauge cannula have you used? That is one. And second, how much is the amount of anesthetic you are using? Initially, you were using how much and how much now?
We used to use about 2.5 to 3 ml of anesthetic agent. With this technique, 1.5 to 2 ml of anesthetic agent is more than enough. And here the outer diameter of this the lacrimal dilator is about 1.067 millimeters. So it just the 27 gauge cannula just fits into the opening. Thank you, sir.
Thank you. I think we come to the end. Any other questions? I think we come to the end. Thank you. We come to the end of this session. and you can just
Yeah,
once the
they
marks
will
are
collect
final.
they collect the mark sheets. Thank you, expert panel, judges, for sparing your precious time and allotting the marks to these young innovators. Thank you very much, everyone, and hopefully we'll be able to see you soon again next time for with much more competitions. And all the best to all the participants. We'll be announcing the results also in the group, and the winners will be definitely informed over the phone as well. So the winners will be collecting their certificates in the next conference in Kolkata. Thank you. Thank you, everyone.